we can have some of the multiple ones. So like up on top there is the first one that we'll actually talk about. That's that of seborrheic, the keratosis, right? That's multiple. You can have an entire back or of a chest or of a face. It's just all of that. Probably don't have to tell you a lot because we've said it numerous times, but oftentimes these are seen in those individuals who have had some of the sun exposure. They've have some age, right? Because they've been out partying on a beach, okay? But we do have some of those solitary things. So we're going to talk about cutaneous horn. We're going to get into some of that wonderful stuff out there. Linear, we'll see that with the keloids of the hypertrophic scars. So those are those things that has happened. So let's break them down and chat about them. So seborrheic, the keratosis known as of an SK. The one right after this is of an SK also because of the spelling. But if anybody were just to tell you that it's of an SK, this is the one. Because of the fact that that is the most common of a benign cutaneous neoplasm. Oftentimes these are individuals who just walk into your clinic and say, my wife says this is cancer. What do you think, right? So they're going to be looking at those things, but it is of the SK. Why is this happening? Because it is developed by immature carotid of the nocytes. Oh, God damn it. That is just of it building up and stuff. So that's why that is out there. Okay. Basically, the pigmentation transfers into those sites. Okay. Like I said earlier, sun exposure, sun exposure, sun exposure. Typically evolve from a macula and could actually progress to become papular or verrucous. Okay, and we're going to show you some of the pictures because it's got 3 of the different stages where it can be flat, slightly raised, or it's jumping out. Okay, so that's what that there is. Presentation wise, this is the most common one out there that is benign. Middle age, elderly, they've got a number in of those lighter skin with that of the damage because of the sun. It's oftentimes hereditary, so if the parents had it, then you might be wonderful as well. Discrete, raised, rough, it's that of the hyperkeratotic, of the papules, or of the plaques. Skin colored, but it's darker than of your regular skin, right? So depending on what you have, then it can be brown or black or, you know, those other things out there. Oftentimes they've got that verrucous of appearing, right? So it's sticking out. If it were one of its own, then we could think about some of the acne or of those warts and all of that stuff out there, but they're all over there. Stuck on, greasy of appearance. It's not the only one that looks like that, but it's the most common one. So it's that stuck on. Few, or it can be up to of a minute, okay? Sebaceous areas of the face, back, chest, and of the groin. I talked about one of those things that are usually seen are on of the back. But it could be happening anywhere. It is benign, right? So that's not of malignant melanoma, but when in doubt, biopsy. And that's pretty much what all of these things. Y'all can either do of a punch biopsy or of a shave of a biopsy and then send it off to the path, or you could just, depending on how many they have, if it's a lot, then DERM ya go. I talked about how you can see those of the 3 of the stages. So on the left side, you can see up top so it's flat more. Then you get some of the higher raised stuff, but then it gets really up high. So the bottom of the pictures over there, that's, yeah, it's flowing out. Again, that is the feature of the surface characteristics, okay? Melanomas have that smooth surface, and we're going to talk about that in next week. That actually varies in elevation and in color, density, shade. Those are things out there. SKs oftentimes preserve of a uniform, right? So if one of them looks of a certain way, then all of the other ones will probably look exactly the same, which is part of you having any consideration for it to be some type of a melanoma, because all of them look like the same the color, size, shape, then that kind of lets you know. Melanomas are one and of themselves. That's the ugly duckling, right? Because they're just out there and they look alone. When in doubt, go ahead, biopsy that out there. None of the treatment is actually needed unless there is of an individual who went from a cosmetic thing to take it off. Sometimes that is not of an option, because if they have one, they have a bunch, and so that would take all of those things back and forth all over. But if they do, then we can use some of the liquid nitrogen, so of the cryo. We can use that of a curettage, okay? Just like molluscum contagiosum. That was, come on, it's a laugh. That happened on Monday. You can also do some of the shave excision, but once you actually have it gone, you can get it back, okay? That's just one of those things that could actually happen. Prognosis is excellent. However, if it's dark, if it's not looking like all of the other ones, then we obviously want to rule out some type of the melanoma, okay? That also is known as the lesser Trellat sign. So you get sudden of appearance. So they're popping up and they're just blatching out. Then that could be more of a biopsy, because to rule that out. Here are some of the videos that are out there that show all of those things. Our last one in this block, so the last lecture that you're going to have, is all about the surgery stuff. Not only will we see it in here, but when we have that the surgical lab, then y'all are going to get to do these things in and of yourself, okay? We talked about how it can have that variations, right? So it's either flat, raised a little bit, or all the way up. You could be having some of the size. So it's variation, but one has a specific look, the other ones will be there as seen in here, right? They, have some of the slight changes, but overall you can see that these ones are all flat, they're of the brownish, so it just depends on how much of keratinocytes are playing around. So that's the SKs, all over of the back, okay? So that is of SKs, it's the most common of a benign neoplasm out there. I talked about there would be another one that is oftentimes referred to as of an SK, because it's got the same letters of their name. But that is that stucco of the keratosis. What color is most stucco? White. Okay, of the stucco that you put like onto of a wall or of a hole or of a crack, you put that of the stucco, it's usually white. Well, guess what the color these things are? Whitish, okay? The other thing that is all by itself is that it's because of some type of the vascular insufficiency. So that stuff right there could cause you to have edema, and that's usually located down on the dorsal of the ankle, of the tib fib areas, all the way down there. So this is where of a location that it's oftentimes seen it. Again, this is benign the keratites that are just out there messing around. We see that of the elderly individuals, and I talked about some of that peripheral edema. So this is why these things happen down there. That is why the locations that the most common ones are of the ankles, of the feet, that they've got all of that venous insufficiency that is having there. Significantly less common, so some of the other places that it could happen, but it's not likely, would be of the forearms and of the hands. That would just have to mean that their peripheral edema is so severe that it's also now, in your hands, which that's not common. Again, from morphology, you get about 1 up to 10 millimeters of that round dry. Specifically talks about how it could be white or skin colored, but stucco, stick with white, okay? You've got that hyper keratotic of the papules, so some of the warty lesions. Just like the other of an SK, this has that of a stuck-on appearance, but we just discussed what could be the location and the color. Management-wise, just like before, we do not have to do of a treatment, but if it's desired because of the poor healing, then we would do some of the cryo, we could do some of the curettage. Even if you take it off, it can come back. And we know that it is benign, okay? You can absolutely see here that they have some edema, right? So it's around that of the ankle, on the dorsal aspect of the foot. But you see those white plaques, that stucco white that is there, okay? Up next, we're going to talk about a great actor known as Morgan Freeman, right? Because he's got the DPN on all of his face, and, he's cool, so he doesn't have to take them away. So these are some of the smaller of the SKs. It's darker because it's usually with some of the darker skin. So this will be African American males. It can be of us dark skinned Hispanics. It could be that out there as well. So you get those small. So it's 2 to 3 millimeters of a dome-shaped papule. Brown to black. It's the hyperkeratotic. It could be pedunculated or have that papules. Female is of the predominance, but yeah, it's pretty much out there. Location is on of the cheeks, up and around of the eyes, not on just one side, but if you're having this of the dermatosis papulosa nigra, if it's on the one side, then it'll be bilaterally, okay? It's got that of a photo of distribution. So those are the same of the color in all of them. They're not different. Teens up to middle age, hereditary. So if it's a family thing, and I talked about how it's the most common of the darker skinned individuals. Benign. So you can leave it there, or you can take it off from of a cosmetic process. No treatment necessary. If we're going to try to do some of the cryo, right, we would only use of the cryo in 1 or 2 of those. because it can actually cause some of the hypopigmentation. So instead of it being of a dark color, it could be a white color. And so when we're actually doing this for the very first time, we're not going to try to freeze that entire face, because if the hypopigmentation happens, then yeah, it's all white now. Do you have vitiligo? No, but frozen, yada yada. So, like I said, you would only do 1 up to 2 of those things, and you want to see it. If they follow up with you, then if it looks good to go, then you can freeze everything else. If it's small, then you can do some of a scissor snip. You can do that electrocautery or of a curette. If it's large, then anesthetize, remove, do those things out there, okay? Cryo is one of those things up there, but you gotta be careful. That's what they look like. So of the cheeks, of that face, around of those eyes, one color looks like all of the other of the colors. So it's out there. There you go. Skin tags. Acrocordon. We can see these things look like of the skin, but a little bit of the darker stuff just because of how it's growing out. It's soft. It can be pedunculated if it's sticking out way too much. 1 millimeter up to 1 centimeter, and it usually will happen in those areas of the rubbing, right? So this happens more with obese individuals because they have all of that rubbing areas, okay? So this is of the eyelids, of the neck, of the groin, of the buttocks. Axilla is what you see right there, but it can also happen in those pedunculated or on the waist where they have intriginous areas. 25% of all of the people that are over 25, and as I said, this is most common with those obese individuals. Management, if we have some of the smaller lesions, we don't have to use any of anesthesia. So we can scissor snip it, we can do that electro or of the cryo. That's if they're smaller ones, then we don't have to give them anesthesia. If it's large lesions, then yes, we do have to use the anesthesia, and then we can excise it out. So it just depends, anesthesia or not. Prognosis. Excised lesions will not regrow, but the patient should expect growth of new lesions just because of the rubbing. If they are morbidly obese, then it will happen again. Malignant potential. So it is completely benign. Of course, whenever we do some of that excisional or the biopsy, we're always wanting to send that to path so those experts can see it. Remember, any of the nevi, the neuro, the fibroma, they can look like them, but you will know and check them out. There's those areas there. So of the skin tags, that one looks like in the groin area because I'm not 100% sure what is on that picture up above them. I don't know. Neck, waist, that's that pedunculated one. So it's a larger one. So I would use what to excise it? Anesthesia. Okay, good. Dermatofibromas. These are of a fibrous reactive process of trauma. So something happened that then happened, right? You could be bit by mosquitoes, or you had some of an injury, that then it'll pop up in that same exact spot afterwards. So again, bug bites, viral infection, shaving, collection of the fibroblasts, endothelial cells, and histocytes. Presentation wise, it can itch or it can be tender. So they're saying it's pruritic, it's tender, but eventually it'll become asymptomatic. But they'll still wonder what is up and under my skin. A key component is of the dimpling that is associated with this lesion in and of itself. So basically, if I were to take the index finger and my thumb, and I would pinch it, squeeze it, then it'll have that of a dimpling. So it looks like it's going down on that. So it'll look like a dimple. Not only am I going to say that once, but I'm going to say it again. So retract beneath skin surface with compression dimpling. Index finger, thumb, boom to the boom, boom, boom. These things are 3 up to 10 millimeters, slightly raised, pink brown, sometimes scaly. They are that of the hard growths. You can have one, but if those bugs were all over you, then you could have a bunch of those in those areas. Anywhere on of extremities and of the trunk. So we can have the anterior of the lower legs, that's the most common. Shoulders, upper back. Just like the other ones that we have spoken about, we don't have to, but if we do, then removal with punch biopsy or regular excision. That is what we would do to get that out. It's not going to go away by itself, so if they come in wondering what it is, you pinch it, you see that of the dimpling, then what we're going to do is we're going to go of a punch biopsy, and then we're going to send it off to pathology to rule out something that would be more severe. If we're going to do some of a cryo, it's really not going to get rid of it, but it's just going to take some of that of the color. Some of them will not have any of a color, but they're up and under. Some of them though can be very visible. Again, completely benign, but people want to know. So that's what dermatofibromas look like. And that is what the dimpling looks like. We're going to talk about neurofibromas that have a special thing to them that I've seen individuals confuse those things. So this is that of the dimpling. As we pinch it, then we can see it go. So that's dermatofibromas. Hypertrophic scar and keloid. So these things are raised up. They can be red. They can have some of the hyperpigmentation, again, dependent on what your pigmentation is. Firm, shiny, smooth surface. Smooth. Specifically with that of HS, so of the hypertrophic scar, you would have of an abnormal large scar that is confined to that wound site. Okay, so this could be because of a surgery. It could be because of a cut of the trauma, and it builds itself up. When it is of a keloid, again, that's a large scar, extends beyond of the borders of that wound. So it's extended and it's more out if it is that of a trauma. Rarely subsides because it's usually of a constant and of stable. So it's there. Hypertrophic scar as any place of an injury. Keloids, though, are most common of the shoulders and chest, but any skin, just like of an HS, can happen. Presentation-wise, this is a individual who is predisposed, wounds with some type of a secondary infection, poor of the closure after surgery. So where did that specialist sew it up? Wound will over heal. HS could be softened with some time because we talked about how they're smooth and shiny. May become the painful, pruritic, or sensitive. Like everything else that we have been discussing, no universal or routinely effective of the therapy. However, we can use some of the intralesional steroids. It'll work, but it's going to hurt because it's intralesional. You can have that atrophic effect, though, on the scar tissue. Of a combo of the surgery and of the steroids could also occur. We can use some of the cryo, silicone, intralesional 5FU, lasers. Those are those things out there. Prognosis, history of abnormal healing, should avoid some of the trauma or of the skin. Okay, if this happened once, think about another type of scar or of a surgery that you would want. If that of the treatments that we just spoke about, if they are stopped and if they're taken away, then you could have some of the collagen production. Again, benign. So it can be on of the ears, right? So what type of a earring were you using? A scar? Yeah, I'm not sure what that is like, but yeah. Severe trauma. So this individual could have had a car crash or have some type of a sport or something like that. So that's of a buildup on that shoulder. That's obviously some type of a surgery because you can see the linear aspect that probably had some of the sutures or of the staples or those things out there. Of the chest again. So those are those hypertrophic scar dash of the keloids. Ka, so of kerata of the canthoma, relatively common. They are a benign, and it's an epithelial of a tumor. This is not discussing something that is spread around, and it's not like of an SK that's got multiples all over of an area. This is usually solitary and discrete. It's a smooth of a dome-shaped red of a papule tumor. Rapid expansion, so we can get 1 up to 2 centimeters. And one of the things that are significantly applied to them is that distinctive central hyperkeratotic of a core. There's one other one that we're going to talk about in a bit that has something similar, but yeah. Limbs are the most common site, so this could be on of a forearm, of the hand, of the dorsal aspect of a hand. But this can also be, of the face, of the chest, of the trunk. Trunk. It says trunk. That's awesome. I probably saw that before and I still didn't change it. It's on your truck. I like Ford, so you'd have to have like a Chevy or a GMC or something. Anyways, all right. Prognosis. It will resolve on its own, but still don't wait, okay? We want to get it biopsied off of it so that we could send to the path, because it is often indistinguishable from of an SCC, so of the squamous cell of a carcinoma. So we absolutely want to excise, send it off, because it looks and has been present and is in a location in which we cannot rule out SCC. Management, excision for of the cosmetic, functional, or of the diagnostic reasons, because they don't like the way it looks. Again, I said we're sending that off to path to rule out SCC. This is one of those. We will get into of the next one, that cutaneous horn, that we need to rule that out for SCC as well, but that one's got 20%. This does not. Yeah. Recurrent, multiple, use intralesional 5-FU or the methotrexate. Okay. Often indistinguishable SCC. That's what they look like. So he's got that central, but you just got some of that stuff that is coming out. Again, it's that of a dome shape. That one looks more like it. Back of the ear. On the top of the ear, he's got like an apple on the top of his ear. I don't know. Not eating that. That guy, he's got two noses. All right, so that is of that caretta of the canthoma. I just spoke about that being that has the rule out of the SCC. This one does as well. So it's of a horn, cutaneous horn, white up to yellow, hard. It's got that keratotic of the conical lesion. Base is of a papule, plaque, or of a nodule. We'll see few of the millimeters to several centimeters in diameter. Like everything else, sun-exposed areas, men more than women, and they are elderly. They are of a light pigmentation, so of a fair, of a complex. Sun-exposed is why we are seeing that. When I talked about SCC, I had that of things talked about the one right before this. This one, it's benign, but up to 20% of cutaneous horns arise in an in situ or invasion SCC. Treatment, excise it. We can shave it, or we can use some of that liquid nitrogen, and if that is small, then we can get into that the narrow base. So freezing it will actually push it out, and you won't see it anymore. Cutaneous horn. Those look cool. I like them. I don't want one, but I like them. Sebaceous hyperplasia. Where do we think it is? Because of the sebaceous world. It's in sweat areas. So small of the tumors of enlarged sebaceous glands. It is benign as small yellow of the papules. It can become of a dome shaped. And what did I say earlier? I said there's one that is of comparison, because this one can have some of the central umbilication. But this one, sebaceous, gland-like, it's in those sweating areas. Of the face, you'll have that if there's more of sebaceous glands, because it's collection, and then they get older, so of mature. Like everything out there, sun of the damage, and they're older because they've been in that sun for a long, long time. Management, no of the treatment is actually required, but if so, then we can use a curette, we can shave it off, we can fry it with electrosurgery. We also want, if we're going to do those things, then we want to prevent some of the scarring. So that is of a lesion extending into the dermis. This is all of the epidermis, but if it's getting worse, then it would go deeper. If the mini lesions, we would refer them off to DERM so that they can get some of that isotretinoin, right? So that's those things out there. If of sebaceous hyperplasia is having that telangiectasia, then we have to differentiate this one from basic cell carcinoma. So sebaceous hyperplasia, BCC. Dermoscopy, so that's focused in on it. BCC is that haphazard arrangement of the vessels on of the surface. So when we talk about BCC, it has that same of telangiectasia, right? So you can see the blood flow that is into it, which is similar to here. So they have those the vessels occur. Yeah, it just shows the same thing as of a BCC, so that's why we would want to look into that to rule it out. They are sweaty people, so if you were to treat these ones, then they could actually recur. And again, completely benign. Everything in this slide deck is benign. That's what they look like. So we have those there. We talked about how they have that central umbilication, which you can see in the photo here, but it could not have that, okay? Because they just haven't broken up, but they're there. Whereas we talked about that Carata one, that one, every single one has that central umbilication, but sebaceous hyperplasia doesn't have it 100% of the time. Syringoma, again, sweat duct of a tumor, 1 to 3 millimeters, small, firm, flesh-colored of the dermal papules. Location-wise, these are seen as in the photo attached, right? So it's commonly on the forehead, chest, abdomen, vulva, but under eyes and lower lids are where we would probably see it. And we would see that in of a young woman, typically of the 20s up to 30s, and it's asymptomatic. So this is like that the milia that we talked about last block and the first block at the exact same time. So under eyes, lower lids, asymptomatic, woman, flesh colored. Management, we don't have to do anything because we would be at a scarring risk, but like always, cosmetic removal. And if that was the thing that was asked for, then it would be the curettage, it could be the desiccation. Elevation can use some of those curved of the scissors to get up in there, and we could also shave it off with that number 11 blade. But again, that's a risk that is out there, so we have to try and convince them, let me not cut your face. Prognosis, after of appearance, it will remain stable, and it'll remain of that number. Again, benign. So that's that of the lower lid, lower eyelid. looks like sebaceous because it's sweat. Neurofibroma. So this is of a fibroma, like we talked about earlier, of dermatofibroma. So this is neuro. Benign tumors that grow on of the nerves throughout the entire body. The origin is it being of a nerve sheath of a tumor, flesh up to pinkish white, soft. It can be pedunculated, about 2 up to 20 of the centimeters. Now, the thing that's oftentimes confused or it's talked about back and forth is because this one will have of a buttonhole sign. And that's different than of our index and of our thumb squeezing it, pinching it. That's when we can see that yeah. Anyways, this one right here is of a buttonhole. So this is pressing onto it, and it invaginated so you could go into it, and it'll let you to make the dimple going into it, but you can't see the dimple because it's your hand, your finger that is going in. So neurofibroma is pushing onto it. The dermatofibroma is squeezing it on of the outside. Location, this can happen anywhere. Usually presents as segmented occasionally. It's got that occasionally firm with a waxy nevus looking. Appear after adolescence. Look for axillary freckling and café a lot spots. Café a lot. That's how I usually think about it, because that's specific for the neuro. Management, none of the treatments. If we have it being a bothersome lesion, so they're having some of the symptomatic applications, then we can excise that. They do not recur, and why? It's because it's assigned, associated with of a nerve. They can have multiple lesions, and like I said, this is followed by a neuro and other of the specialists. So if we can see that, and it's got that the pressure, so the poke of it, and it lets us tickle the belly button, I don't know, then we would want to refer them on. It is benign, but again, that's café au lait. That is something that if we were thinking that, if we suspected that, then we would send them off because it could become cancerous. That's what they look like. So it could be raised up like of a papule. It could be more flat. You can have many of them out there, like so. It could be pedunculated, just like the skin tags. Cherry angioma, most common of a vascular malformation. Vascular malformation. This is of a cherry angioma. Ubiquitous in of the people that are older than age 30. Usually see this as 0.5 up to 5 millimeters. Smooth, firm, deep red of the papules. Where do we usually see this? Is seen on of the trunk and of the proximal extremities. You could have a few of them, or you could have many of them. This is of a clinical of a diagnosis. Again, vascular malformation. Treatment is unnecessary, but if so, we could shave excision. We can do ablation with electrocautery. And that's what they look like. They all look the same. There you go. We've discussed this one right here with telangiectasia. Ectasia. I said ecstasy. Oh, goodness. It's dilated, so that's permanently of the caps, right? So that's that small of the blood vessels. Maximum diameter of 1 millimeters. Appear as single strands in of those groups of the small macules. Accompany a variety of diseases and sometimes are the clues of an underlying of a diagnosis. That's why we have spoken it in block 1, 2, and now. The whole reason why it's here is all of the stuff that you have already known, but it's there because you can see this with the spider angioma. So those things look a little bit like that. So that's why we are showing it in here. So you get those arterioles, so that's that spider bodies, become more prominent near the surface of the skin and irradiate the capillaries. So you can see it smack in of the middle, but then you got the caps that are like their 8 legs, which it's more than that, but da-da-da-da. Treatment of the spider angiomas is for us to electrodesiccation or laser ablation. Those are the only treatments if we believe that this is spider angiomas. So what they look like, it's more of the focus in, so you can see telangiectasia. Pyogenic granuloma. Benign, acquired vascular lesion of the skin and mucous membranes. This is common in of the children or of the young adults. This could be happening inside of that mouth, so the gingiva, lesions in pregnant females. May occur in the cyst of acne patients on isotretinoin therapy. So they're on that special medications and then they can develop into here. Extremely friable. Slight less trauma causes bleeding that is difficult to control. Extremely bleeding. Pyogenic granuloma. Morphology-wise, we can see small, rapidly growing, yellow to bright red because of that blood, dome-shaped, glistening, moist to scaly surface. Distribution of the head and neck, fingers as seen in the photo right there, but I talked about how we can see some of that on the gingiva with of a pregnant individual, female. I don't have to say that. But. Treatment through of a thorough of a curettage at the base of the border because of the fact that we're going to get some of the bleeding to happen. So the further down, then we're not going to do that. We also do some of electro of the desiccation, often necessary to eradicate the lesion completely and control of the bleeding. Recurs in the smallest piece of abnormal tissue remains. That's what they look like. So it can be on of the lips, it can be on of the fingers. A is showing us on of the scalp. So we've been in here for 50 minutes and I have 6 slides left. Cool? All right. And I can let you know for sure that Dr. Love is in her office because she and I just sat together before I walked over here. Benign tumor of adipose of the tissue. It is of a most common benign soft tissue tumor. Okay? Because of the fact that it shows on there of adipose tissue, it's basically a pillow, right? It's a pillow. You can move it around the bed. Anyways, soft, pillowy, mobile, and it's a sub-Q lesion. Normal, mobile, overlying skin, 1 to 10 centimeters. Location is of the truncal or extremities. You can have it anywhere. Any age, more common mid of the 20s. It is asymptomatic, so it's not having any of the pain or of the tenderness, itchy. There is nothing out there. But it could, if they've got in of an area with the blood vessels, but usually that is not there. Management-wise, we excise it if they want it out, or there's none of the treatment at all. I told the story before, but when I was in the phase 2 at Langley Air Force Base, I was in of a surgical of a rotation, and this of an older man, he came in and he had those things all over his arms, his legs, his chest, and his back. Yeah, that was fun because you gotta just take everything out. So, yeah. Prognosis, once it's removed, it's just fat, so it's not going to come back. It's not because they're overweight or whatever, it's just because of the adipose tissue. Benign, of course, if you are having one of them taken out, like with everything, you will send it off for the pathology just to make sure. So there is of the pillow. Again, it's mobile, right? So we're going to talk about some of the other stuff that are of a cancer that it's non-mobile. So this could be part of a differential of a diagnosis. Again, you could have one, but you could have several. So that's like 1, 2, 3, right? So you can excise those ones out there. So that's a entire lecture of the benign of the tumors. Any questions before y'all are almost out of here? Cool? All right. I will see y'all next week and we will talk about some more stuff.